Hospital. I happen to be the only pediatric surgeon in the southern area of Zimbabwe. We do have other pediatric surgeons based at Harare Central Hospital. As a pediatric surgeon, I deal with conditions in children generally ranging from birth to around about 18 years, although in rare cases we do see adults that have conditions that they were born with that may be referred to us. The bulk of our work is actually neonatal surgery, where babies are born with congenital anomalies, babies who are born without an anus, babies that are born with discontinued intestines and cannot feed because of that. That's the bulk of our work, especially here at Mpilo Hospital. We also see babies with intussusception. These are older babies from around 3 months to a year, where the intestines have gone into each other and that's causing an issue. We also manage babies that are born with difficulties in passing stools, different grades of that, some that need an operation, some that don't need an operation. We do a lot of other things, but I think the bulk of our work is that. So we haven't done studies for us here in Zimbabwe, but just as my experience since I came back to Mpilo Hospital, they are very common. We are actually a very busy unit here. We operate twice a week, and I can tell you that that is not even enough. So we usually have patients that are waiting for operation because we need at least a daily run in theatre, and that is not possible mainly because I'm alone at the moment. But yeah, we deal with, like today I have 3 neonates that I'm operating. One was born without an anus, and the other one had a problem with the intestines inside, and then the other one also was born with discontinued intestines. So that's 3 in a day already, and in a week you can see up to 7 neonates with that same condition. So it's quite a lot. So I came back here in July 2021. I was an intern here in 2011, 2013, 2014. I was doing my intern and subsequently medical officer duties here before I left to South Africa to do my postgrad training, which was six and a half years. So I was back here in July 2021. That's when I started my senior reg time and then subsequently consultant post in September 2022. But I feel like this is a question that I like to answer, because for me, just seeing a parent who is smiling when they are taking home a baby who was previously not eating or was previously not pooping gives me the satisfaction, because especially in the government sector here, where parents are at your mercy, so to say, they have no other option but to trust you. And so seeing them going home with smiles on their faces is what motivates me to come back to work each day. Not so much of the benefits, the satisfaction of just being a surgeon and enjoying doing what you do. It's more of the satisfaction that I get from thankful and grateful parents and their children when they now go home.
Okay. Alright, my name is Dr. Dani Kushumba. I'm a specialist pediatrician and a specialist pediatric cardiologist. I manage general pediatric conditions and also children with heart conditions. That's pediatric cardiology. Okay, so it's been partially rewarding and challenging as well at the same time. Partially rewarding in the sense that, especially on the pediatric cardiology aspect, you're bringing in a service that was not easily available to patients. So you find that you're making a difference in the sense of you diagnosing conditions that you were being diagnosed late or were not being diagnosed because there were a limited specialist in the country to be able to provide the service. So that's kind of rewarding, and you'll be able to provide the diagnosis, provide management plan for the patients. So for conditions that probably were thought to be not compatible with life or not manageable, or a child was thought that they'll be chronically ill for the rest of their lives, you're actually offering them some kind of hope that there's actually treatment that can be offered. The downside of it, or the challenging part of it, is the management aspect of it. It's not readily available currently in the country. So you find that for most of those children you diagnose with heart lesions, mostly congenital cardiac problems. By congenital, I mean it's a problem that the child has been born with. So you find that you tell the parent the problem of the child, and you tell them that there is actually a solution that can be available, but you can't make it available because it's not yet available in the country. So that is the challenging part, in the sense that you've just given some news to a parent, but it becomes bad news in the sense that you can't provide a solution to the problem that you've told the parent. So most of those cardiac problems, they're actually treatable. So there are two ways in which they can be managed. One of the ways is through cardiac catheterization, which is a form of minimally invasive procedure where you go through blood vessels to go and correct defects that are in the heart. That is what I trained to do. The challenge is, at the moment, we do not have that kind of theatre, which is called a cardiac catheterization lab, available. So that service cannot be offered. And then the other second arm of the treatment is cardiac surgery, whereby it's done by cardiothoracic surgeons who go and open up the heart, and then they go to where the defect or where the problem is, and then they fix it and then close up the chest. So for that, we've got a few cardiac problems that can be managed at Nyatwa, but the bulk of what our children are facing, they are not yet being managed. I understand, I think it's something probably in the pipeline, but we're not there yet. So a lot of the patients then, they would have to find other alternatives, like mostly leaving the country and going to find the help somewhere outside the country. It's depressing when you can't offer a solution. I don't want to lie, that's to say the least. You know, when you've like during the training, you'll be at a center where things are available. So you see a child, just as an example, those with a hole in the heart, and they have many admissions because they are ill most of the time with chest infections, and then they do go on to have an operation done to close that hole. Soon after the operation, they are well. You review them after a few months, they are running around, they're just growing normally. And you know that that can happen. So now if you go through the same scenario again, you diagnose a child with a hole in the heart, you see how they're struggling, but you can't offer them anything. It's heartbreaking, I don't want to lie. So in the end, you're kind of become a bearer of bad news when you could actually be a solution to those kinds of problems that the children are having. Okay, so at Mpilo at the moment, we're still putting our statistics together. I started, and this is my second year there. We are in the process of trying to put the statistics together. But generally, 1 in every 100 children is born with a congenital heart defect of varying severity. Sometimes it may not be severe, sometimes it's quite severe that needs urgent attention. So it's a common problem that we actually encounter. So that's for the congenital heart disease. Then there are some conditions of the heart which are called acquired heart diseases. The common one we see is called rheumatic heart disease. This comes on from the age of about 5 years, and as the child grows, the valves or the gates in the heart are damaged. So that one is very prevalent because it's higher in middle to low income countries. So Zimbabwe is among one of the countries where it's quite high prevalence. So we see quite a lot of those patients. Okay, so for us to be able to tackle the problem properly, so there are several stages. So firstly, we need to raise awareness in the community and among healthcare workers, because the challenge that's also there is that there's late presentation. Patients come after having stayed at home or not realizing that it's a big problem, or they go to save some facilities and unfortunately it's not big, that is a hard problem. And they only present much later when they're actually very sick now. So we need to raise awareness in our community, raise awareness among healthcare workers so that we diagnose these conditions early. Secondly, we've got the expertise in the country. We've got pediatric cardiologists, we've got cardiothoracic surgeons. So we just need to empower our system so that we make the resources available for those procedures. So we need like a cardiac catheterization lab that I was talking about. in our public sector so that it's available to the general public of Zimbabwe. And then we also need the other specialties that we work with. For example, clinical technicians and nurses who are specifically trained in cardiac care. So those would also be the staff that will be needed to make us a complete team to be able to actually do those procedures locally. The advantage of having those procedures done locally is that we'll be able to train more people so that there are more people who are able to do that, as opposed to us trying to keep on sending children outside the country. We're not growing as a specialty in the country. And it's actually more expensive to be sending children out instead of actually having our own facilities available locally.